Be good to get started.
All right. Hi, everybody. My name is Namitha. I'm one of the rheumatologists here at Morgantown. And the topic for today is going to be Lyme's arthritis. Thank you, everybody, for joining. Feel free to stop me if you guys have any questions. We'll also have some time for questions towards the end. But if there's anything that's urgent, please feel free to stop me. So I'll get started. So this is kind of an overview for the topic for today. So we'll speak in the beginning a little bit about Lyme's disease in general. So mainly the causative organisms, the vector, epidemiology, stages. What are the measures to prevent tick bites from happening? Indications for prophylactic antibiotics. And then we'll head into Lyme's arthritis. A little bit about the history, diagnosis, as well as management, the post-treatment Lyme's arthritis conditions, as well as erythema migrans. So about Lyme's disease, the causative organism is Borrelia burgdorferi. It was named after scientist Willy Burgdorfer first identified the strain back in early 1980s. It's a type of a spirochete bacteria, so it's known for its unique corkscrew shape, as you can see in the picture here. And it has this sort of like a twisting propulsion, which is a characteristic for the spirochete group. And then the vector is the Ixodes tick. So black leg tick, Ixodes scapularis in the northeastern US and upper Midwestern US, and then the western black leg tick, which is Ixodes pacificus along the Pacific coast. And this is a picture of the Ixodes tick. So epidemiology, as you can see, kind of like based on the distribution in US, and this is updated as of 2023. You can see it's mostly the northeastern part, a few scattered dots here and there throughout the country. And then specifically for West Virginia, if you look at it, all the counties have reported cases of Lyme disease. And so it is pretty common, especially in our state. As of October of 2024, there were around 2,867 cases of Lyme disease, with every county reporting it. And in the US, there's been approximately 476,000 patients who have been treated. So, what are the stages of Lyme's disease? So, there's an early localized disease, which is usually following the first 30 days after the exposure, usually kind of similar to a flu. So, there's a rash, which in case of the Lyme's disease is a specific erythema migrans, and then fever, arthralgias, and headache. And then after that comes the early disseminated disease. So you start noticing it's a little more spread out now through the organ systems. So you do have the systemic manifestations. So the rash, fever, arthralgias, headache, lymphadenopathy, and then it starts affecting, the heart and the CNS. So a lot of arrhythmias, myopericarditis, myocardial dysfunction, and then from the neuro standpoint, aseptic meningitis, which is pretty common, the facial nerve palsies, and then some degree of like a radiculopathy. And very rarely, sometimes it can cause a conjunctivitis picture. And then the late disseminated disease. So that's after 3 months. And that's when we start noticing the true Lyme's arthritis, along with some of the other CNS complications and then retinitis. So if you look at the stages, you will notice that, I have arthralgias mentioned at every stage. So the first two are basically just, the generalized aches and pains, kind of like a reactive arthralgia. Whereas the last one, which is in the late phase, that's what we are mainly concerned about when we say the Lyme's arthritis. So, what are the measures to prevent the tick bites? So, personal protective measures, wearing long sleeves, you can use insect repellents. And then, if you do have a tick bite and you notice that it's attached to your skin, they do recommend kind of getting that tick removed. So, you use a fine tip tweezer and you try and insert it between the tick body and the skin, kind of like in the image here. Do not try to burn the tick or use any form of like a noxious chemical or petroleum agents to kind of force the tick to detach on its own. Just use the tweezer or a similar device to kind of get it out. So indications for antibiotic prophylaxis. So it's usually for adults and children within 72 hours of removal of an identified high-risk tick bite. And what are the features that make the tick bite a high risk? So if it is identified as the Ixodes species, it's highly endemic area that is greater than 20% of an infection rate. And if the tick has been attached for more than 36 hours. So if you have these features, and it's been within 72 hours of removal of the tick bite, you can go ahead and give an antibiotic prophylaxis. Usually it's doxycycline, 200 milligrams is a single dose for adults, and then 4.4 milligrams per kilogram for children. Now, if doxycycline is contraindicated, then do not give any other alternative antibiotic as a prophylaxis. In that case, you would just do a wait and watch approach. So we'll now start talking a little more about Lyme's arthritis. So the classic things we'll be focusing about is basically the history, how to diagnose, and how to manage. So usually it's a big knee. Because the knee is a common joint that is involved. We'll talk a little bit about the IgM trap, which is a little confusing and kind of puts us in a lot of diagnostic dilemmas. And then we'll talk about the management. So the history of Lyme's arthritis, originally it was recognized because there was an outbreak of monoarticular and oligoarticular arthritis in children in a place called Lyme in Connecticut in the 1970s. And so that's how the name Lyme's arthritis kind of came out. Prior to the use of antibiotic therapy for treating this, about 60% of the untreated patients did develop Lyme's arthritis. Basically, the spirochete strains are disseminating to the joints, tendons, or bursae earlier on in the infection. So they usually end up having like an asymptomatic or transient migratory arthralgias. But then when it's coupled with the innate and adaptive immune responses, which happens a little later, that's when the true arthritis phase starts. So remember, the joint is a late destination. It's not the first stop. So like we discussed, the early localized with the rash and the viral symptoms, followed after a few weeks with neurologic or cardiac disease. And then after 1 to 3 months, that's when you start thinking about Lyme's arthritis per se. And usually by the time you reach to that, late disseminated phase, the two-tier antibody testing that we usually do for Lyme's disease should be positive by then. So I have a case that we'll kind of, keep following through the course of this talk. So we have a 52-year-old with 3 weeks of progressive right knee swelling. He's able to bear weight. Pain is around 3/10, no fever, systemic toxicity, loves to garden and hikes a lot in West Virginia, but he doesn't recall any tick bite or a rash. And on examination, you notice there's a large warm effusion, but there's only limited pain on range of movement. So what would your first move be? Either treat empirically for Lyme's, order a Lyme's IgM testing, assess the septic risk in two-tier serology or the MRI. And I have the answer highlighted, but basically the main thing to kind of remember here is any patient who's coming in with a single joint involvement with a degree of significant swelling, some degree of pain, just because you think that this could be Lyme, please don't forget to rule out other conditions. So like a septic arthritis safety check needs to be performed. And if you are skipping this and you start treating for Lyme's without ruling out a septic arthritis, it could kind of worsen going forward. So just because your suspicion is high, please do not forget to rule out a septic arthritis. So 5 key decisions to be made, when thinking about Lyme's arthritis. First, recognize the classic phenotype and know what doesn't seem to fit. Protect the joint, which is basically, rule out a septic arthritis, because that would require urgent intervention, surgical involvement, and things like that. Test correctly. So we would usually recommend a two-tier serology. Sometimes you can do aspiration in select cases. Treat once and then do have an appropriate reassessment of the response of the patient and stop antibiotics when it's not indicated. So how do you, when do you start thinking about Lyme's arthritis? So there's a big effusion. Surprisingly, there's only modest pain. So it's not like, a classic patient who would come in with like significant pain and swelling. They're not able to move the joint at all. That should make you think maybe there's something else going on. So here, there's usually swelling out of proportion of pain. The knee is the most common joint that is involved in a classic Lyme's arthritis. Swelling, less pain, intermittent or migratory episodes are possible. So they might tell you that, they have pain for a few days and then it kind of resolves and then it starts coming back. The swelling seems to be fluctuating a little bit. So kind of you will have that migratory possibility as well, where they're like, okay, today it's this joint, the next day it's kind of like something else. So that is also possible. And usually it's lesser than 5 joints, so it's an oligoarticular at the max. Rarely is it polyarticular. So small joints or systemic toxicity should slow you down. Like I said, if you notice that, there is a symmetric MCP or PIP involvement, the hands and the feet are the main concerning areas. There's significant pain even with minimal movement, or they have like, marked cytopenias. So that case, you should start thinking about alternatives here. So like, is it a true rheumatoid arthritis maybe? Or is there another infection that's going on like anaplasmosis or babesiosis? Usually when it is Lyme's, like I said, there's minimal fever, they're able to bear weight, and then maybe think about the epidemiology. So like, did they maybe go outside somewhere? Was there a possibility of an exposure, even if they don't recall the tick bite per se? So Lyme's arthritis means objective joint inflammation. It's not just a chronic diffuse arthralgia. So that should also kind of, be remembered. So, what are the differential diagnoses? You have a patient who's coming in with this knee pain, swelling. What else should you think about? So, first and foremost, is septic arthritis, crystal disease. Knees are a common site where we can see gout or CPPD. If there's trauma, like a hemarthrosis, a meniscus injury, reactive arthritis, so they might report like a recent GI or GU involvement. And then the inflammatory arthritis, like there is no rule that rheumatoid arthritis, just because we say it's a symmetric polyarthritis, cannot have a mono or an oligoarticular presentation. It is possible. So please rule out, such inflammatory arthritis. And then other infections like a viral, mycobacterial, fungal. And remember, even if you have a positive Lyme's test, please do rule out these conditions because it can oftentimes coexist. So there could be a secondary infection going on, or there could be, say, for example, chondrocalcinosis in the knees, and you should start thinking about like CPPD in that case. So safety first, again, I know I'm harping on this a little bit, but this is something that we tend to miss very commonly. So if you still have concerns and you're not sure whether, Lyme's would be the only etiology, don't hesitate to aspirate the joint. Especially if the patient's also reporting some systemic symptoms, not able to bear weight. There's a superficial infection nearby, like, say a cellulitis, or there's concern for a deeper osteomyelitis. Immunocompromised patients or patients who have a prosthetic joint have, say, dialysis lines in, raising concerns for like bacteremia. So in those situations, it is fair to kind of consider an arthrocentesis at that time as well. So if you end up aspirating the joint, you can get synovial fluid for analysis, and then you can send the Lyme's PCR. So that is also a diagnostic possibility. So how do you usually diagnose the patient? So we follow the standard 2-tier testing, which is the first one is the ELISA test that's commonly done. And then that's kind of the screen. And then you go into tier 2, which is basically the Western blot, wherein you're looking for reaction to specific IgM and IgG strains. So if you notice, with positivity of 2 out of 3 against the IgM or 5 out of 10 IgG bands, then that is a confirmatory Western blot testing for Lyme's disease. And there's a modified 2-tier where you do an ELISA screen initially, and you can do a different type of ELISA testing as the second one. But I think common practice is to just go ahead with the screen followed by the Western blot for confirmation. So if tier one, that's the screen is negative, please do not test further. Don't order both of them together. It should be a step up approach. If the first screen is positive or equivocal, then you go for the Western blot, which is tier two. And the overall result is considered positive if only if the two-step process has been complete and both of them are positive. Don't skip the ELISA screen and go directly to a Western blot because it would be difficult to interpret at that point. And so I mentioned the IgM trap initially. So disregard an isolated positive IgM result. It has to be that expanded IgG response as well, along with a positive screen. Also note that with the two-tier serology, it's usually positive in 95 to 100%. So it's a pretty good sort of a sensitivity and specificity for this diagnostic testing. A negative recommended two-tier test makes Lyme's arthritis exceedingly unlikely. It's not impossible, but it is unlikely. And remember that antibodies may persist for years. So if you have a patient with Lyme's arthritis, you have treated them, and you're like, they're still reporting some residual pain or swelling, don't try to do serologies again because you're going to see that serologies can be chronic and they stay positive for years. So, it is not a good idea to keep testing the serologies because it's going to stay positive and it's difficult for you to kind of make any assumption from that. And if you do only the IgM testing, it could lead to overdiagnosis just in patients who have like chronic joint symptoms. So when you're tapping the joint, don't just think about Lyme's disease. You have an opportunity, you have a tissue sample here, right? So with the fluid, you can definitely send out the cell count and differential. You would expect to see an inflammatory fluid. So like with a high WBC count, you can send for the ground stain and bacterial culture, especially if you're concerned maybe there's a septic component. Crystal analysis, very often, like I said, it's definitely possible that it can coexist even in patients who have a positive Lyme serology. And then the Borrelia PCR is an adjunct. It's never the first test. So definitely try it only if you find that the serology is positive in the first place, but you're still kind of trying to make sure that the diagnosis is certain. And again, as with the serologies, the DNA may also persist after therapy. So do not try to do this as a test of cure. We usually do not recommend doing a synovial fluid antibodies testing. Usually it's just the PCR for the synovial fluid. How about imaging? So, we do ultrasound nowadays for the joints. We can especially use that if you're trying to aspirate and you're having difficulty, or if it's an atypical joint involvement, like a hip joint or a shoulder. So it helps to kind of confirm the presence of fluid and also get access for aspiration. You can do an X-ray there. You're trying to rule out other alternatives, like is there a fracture? Is there a foreign body? Is there advanced OA? So just, another structural clue. And then the MRI is usually for complications. So you're still concerned that, you've treated the patient, still not improving. You're concerned about other alternatives like, osteomyelitis or pyomyositis, or is there an abscess formation? So usually for complications. And so now we're just going back real quickly to that patient who is here with the knee swelling. And so because there was initially some concerns whether, Lyme's is the only thing going on, they ended up getting some diagnostic testing done. So serum two-tier testing was positive. The ELISA was positive and did have an expanded IgG response as well. So that's more than 5 out of the 10 IgG bands. The synovial fluid is inflammatory, so 42,000, so a high WBC count with a neutrophilic predominance. There were no crystals that were seen on the arthrocentesis, and the ground stain came back as negative. So in this situation, this kind of helps, right? So we've ruled out crystal disease. It doesn't seem like, there's an infection that's going on. So septic arthritis is also ruled out. And so now we can kind of try to confirm, yeah, it sounds more like Lyme's arthritis. So in this situation, the next step would be to start treating the patient. So it would be a 28-day oral regimen of doxycycline. So It is IV therapy we do not recommend as the first step. So remember, the first way to treat a Lyme's arthritis patient would be just an oral regimen of doxycycline, 100 milligrams twice daily. Alternative antibiotics that can be considered include amoxicillin and cefuroxime. Again, choose by age, pregnancy, if there's any allergies, adherence. Some patients may not like to have like a 3 time daily antibiotic, right? So make it a little better for them twice daily. Think about co-infections. Is there anything else that's going on? Maybe drug interactions. So we do have some options for the oral therapies here. So once you start the antibiotics, right, you're giving it for 28 days, and the patient comes back and they have some swelling still. So it is better than before, but it's not completely resolved. So remember that, even if you're completing the antibiotics, the complete resolution might take some more time. So around 1 to 3 months, and 90% of the patients tend to kind of have symptom resolution at the end of like 1 to 3 months, even if they did not have complete resolution just at the completion of antibiotics. So again, like I said, there is no diagnostic test to know about the cure. Just follow the joint clinically. So what are the changes that we're expecting to see? So initially when, as you can see in the picture, the spirochete, let me see if I can bring my pointer up. This is a spirochete that's actually entering into the joint. And initially you're seeing, there is an inflammatory response that's happening. And so you're seeing a lot of different types of inflammatory cells that are kind of coming into the area, trying to fight off the spirochete. When you start giving them the antibiotic, there's more tissue repair. So you're seeing more blood vessels, so there's more vascularization, more fibroblasts and macrophages that are kind of coming into the picture to try and get the spirochete out. And then once there is late repair, you will notice more fibroblasts and a lot of collagen formation. So that's kind of like the scar tissue formation. So a follow-up, so you're noticing that, this patient's completed the 28-day oral therapy as always. And then you're noticing, there's still some persistent swelling. So recheck the diagnosis, make sure that, you didn't miss out on anything. Make sure the patient was adherent to the regimen, and then you assess for the joint response. So if there is a partial response, like there's mild residual swelling, but clearly smaller than what it was before, so in that case, you can either observe, maybe give them some pain control like an NSAID, or consider a second oral course for up to a month. Or the alternative it's mentioned here, like, either observation or the oral course. I'll talk a little more about that. But then if the patient's not having any improvement, so like no or minimal response with significant effusion still present, then you would just prefer to go for an IV course. So just talking a little more about, in the situations where there is mild residual swelling, so there's no winner between the two. So whether you should observe or give a second oral course, even the guidelines that's from the IDSA and the ACR do not clearly report which option they prefer. So one option is you can give them an NSAID if appropriate, they're able to take it, not on any blood thinners, no gastritis, anything of that sort. So you can continue with an NSAID, give them some rehab, and then you kind of follow up there. So just observation and supportive care. In some situations, you can go for a second oral course, so like up to 1 additional month, and that you can have a kind of like a discussion with the patient as well to decide whether they would prefer to do an oral course or just do observation and supportive care. But do remember, just make sure you are ensuring that this is the right diagnosis. You didn't miss out on anything. Make sure the patient did comply with the first antibiotic regimen. So this is the only sort of situation which I would say, based on this talk, which is based on weak recommendations from the IDSA and ACR. Everything else that I'm mentioning are kind of like, moderate to stronger evidence. But this is the only situation where you kind of take a little bit of patient preference and adherence into decision making as well, and you can have a discussion with them. So suppose the situation is that, the patients completed the first course and they have absolutely no response at all. They say, hey, I tried the antibiotics, I was very adherent to regimen, did not miss any doses, but I'm still having moderate to severe effusion or significant pain still. In that situation, you would consider going for an IV course as the second antibiotic choice. So ceftriaxone, you give that 2 grams adult dosing once daily, and it is usually for 2 to 4 weeks that you are going to give that to them. What happens if after this you are still noticing that there is significant synovitis, like you've completed one adequate oral course and one adequate IV course? In that situation, we kind of reach a condition called post-antibiotic Lyme's arthritis. This is now a true objective proliferative synovitis, and it's an immune-mediated joint inflammation at this point. It is not about antibiotic resistance. In this situation, the immune system is kind of getting involved, and so you have like a true kind of similar to an inflammatory arthritis. So this is post-antibiotic Lyme's arthritis. Some of the risk factors are when there is the RST1 type strain for Borrelia burgdorferi, if they have retained spirochetal antigens, some genetic factors like the HLA-DR alleles or TLR1 185GG polymorphism, if they have ECGF autoantibodies and a decreased ratio of Treg T effector cells amongst the synovial fluid mononuclear cells. So these are just a few risk factors. Now, it's very difficult for you to know any of this without doing appropriate testing. So really just remember that, if a patient's completed one oral and one IV course and they're still having persistent inflammation, we're kind of in the post-antibiotic Lyme's arthritis phase. So then this is kind of the structure that you would expect to see. So this is post-infectious Lyme's arthritis, and you can see that there could be areas of fibrosis where there is a lot of scarring that you are noticing. So a lot of the fibroblast cells, a lot of collagen formation, or they could have this sort of like an area of inflammation. And here you're mainly seeing a lot of plasma cells and cytotoxic T lymphocyte cells. So they're still trying to kind of fight against this spirochete, but it's kind of like a hyperactive immune system. And so you see all of these immune-mediated cells here. So how do you manage these patients? And this is where kind of, rheumatology comes into the picture, mainly with DMARD management for these patients, because now the patient's having kind of like a true inflammatory arthritis. And so here, in patients who have mild synovitis, we kind of choose plaquenil or hydroxychloroquine, weight-based dosing up to 400 milligrams daily. And patients who have moderate to severe synovitis, you can choose methotrexate, depending on their tolerance and their weight. And then in patients who had an incomplete response to methotrexate, you could consider using the TNF inhibitor. So kind of very similar to how you would manage like an oligoarticular RA. You can expect a response by 1 to 3 months, and hopefully the duration of treatment would be like, 6 months to a year. And if the response to the DMARD is also incomplete, and this was just the one joint, that one stubborn knee joint that was involved, then you can consider doing an arthroscopic synovectomy. Now, when you're starting immunosuppression, just make sure you are rechecking serologies. And at this point, you're kind of checking alternative etiologies. So like rheumatoid arthritis, check for a psoriatic arthritis picture, a spondyloarthritis, or is it just really bad erosive OA that the patient's having, or a crystal disease? So before starting immunosuppression, it would be worthwhile to recheck these. And then the second type of post-treatment syndrome is a post-treatment Lyme's disease syndrome. So this can be seen in maybe like 10 to 20% of the patients. They don't really have synovitis or any systemic inflammation, but they're usually reporting, fatigue and widespread pain and cognitive difficulties. Some of the risk factors are female patients who had severe disease to start off with, comorbidities, patients who were diagnosed pretty late, patients who are on steroids. And there's no standard treatment for this, but you could consider this syndrome kind of similar to how fibromyalgia is. So it's kind of that chronic pain and disease that we're thinking about. So kind of the same medications that you would tend to use for fibromyalgia, so like duloxetine, TCAs, Savella or milnacipran, kind of going down the non-pharmacologic measures, so like exercise and CBT. So those would be the options for a post-treatment Lyme's disease. So just remember the two spectrums here. One is a true inflammatory arthritis, and the other one is kind of similar to a chronic MSK pain syndrome like fibromyalgia. So for our patient, by week 4, the effusion was much better. It's 70% smaller. So in this case, you can just continue observing the patient, try an NSAID if they still have some residual pain. But I'm not going to repeat test this patient like serologies or any other testing at this point. So just a few things to remember for Lyme's arthritis, a big effusion, but just with modest pain. If you have a negative 2-tire serology testing, please think about alternative options. Just an isolated IgM is not diagnostic of Lyme's disease. And if you have persistent swelling, don't always just keep repeating the antibiotics courses. Never more than 2 courses, especially if they have significant inflammation. After the second IV course, you should be thinking about starting DMARDs. And follow the patient's need clinically. No diagnostic, test of cure that we have for Lyme's disease. And then just briefly mentioning erythema migrans, because this is also pretty commonly seen. So you can see the target shaped lesion here on the picture, which is the classic presentation for erythema migrans. Again, not everybody is going to come to you with this textbook presentation. So just take it with a pinch of salt if they tell you like, they had a tick bite and exposure and they're having a rash. Just don't rule out Lyme's disease or erythema migrans just if you're not seeing this target shape. So in patients who have a potential tick exposure in an endemic area for Lyme's disease with 1 or more skin lesions kind of looking like this, the diagnosis is usually clinical. But if you have a patient who has kind of similar presentation, but you're not seeing this classic target shaped lesion, you can consider performing antibody testing. And the treatment is usually oral antibiotic therapy. So you can use the same medications that you had used for treating Lyme's arthritis, the first oral regimens. So doxycycline, amoxicillin, or cefuroxime. And it's usually a 10-day course if you're choosing doxy, or a 14-day course if you're choosing amoxicillin or cefuroxime. So take home points for today, I would say for every big knee, make sure you're kind of going through this, sort of an algorithm, protect the knee first, rule out septic arthritis, test appropriately with the 2-tire testing, treat 28 days oral regimen, reassess at the end to know whether it's a good response or no response at all. And anytime you notice no response to the 2 courses of antibiotics, think of it as more so an inflammatory disease. And these are my references, and that would be all.
All right, thank you so much. Do we have any questions?
I just want to say thanks. It was very well organized, very, very easy to follow. It was great.
Yeah, no worries. Thank you.
Thank you, Carmen. Do we have any questions or comments from anyone else?
Well, the graph you showed of the counties in West Virginia was from 2023, I think.
I think it was last updated 2024 for West Virginia. The picture of the United States as a whole was from 2023.
Okay. Because, I mean, my feeling is from talking with patients and seeing patients is that it may be getting more prevalent. and
I
say,
think it is. It is getting definitely more prevalent. I don't remember seeing anything that was updated over the past 2 years. So I think we're still lagging a little bit in kind of getting that updated. So that's why I think they had last updated it October of 2024, if I'm not mistaken.
we have a lot of people coming in wanting the prophylactic dose, which kind
Mm-hmm.
of we give them
Mm-hmm.
because, sometimes it's hard to know how long that tick was there if it's in a spot they can't see.
Yep. Yeah, that is true. I mean, we do have these guidelines which tell us to identify the high risk bites, but oftentimes it's kind of difficult. And we are an endemic area. So I would say, especially if they have that sort of, exposure behavior like, gardening or hiking and things like that, I think it is worthwhile as long as they don't have any other like, side effects or allergies to doxycycline, we could. But yes, we do see a lot of patients who are kind of concerned about this and end up getting that prophylactic doxy regimen.